In 2020, two friends decided to get tested for COVID-19 before going on a camping trip. Both did drive-through tests at an Austin, Texas medical facility. The test came back with the same result: negative. But the bills that came back could not have been more different. One was charged $199, and the other was charged $6,408. How does that happen? This one incident is just the tip of the iceberg. Hospitals have a reputation of hiding prices from patients only to surprise them with excessive bills. Over 50% of Americans have received, or know someone who has received, an unexpected overpriced medical bill. Patients should have the ability to look at prices and choose what service is best for them. So why hasn't anything been done? New laws have been passed, but hospitals are ignoring them. In 2021, Texas unanimously passed and signed into law new rules requiring hospitals to post their prices online. That was a great first step, but the majority of hospitals are still not complying, and when they are, it's not useful. Take a look at this website. Rather than seeing a package price for a procedure, websites like this are riddled with codes for each individual component. This makes it almost impossible to figure out what an in-charge will be for any medical service. Hospital pricing should be clear and useful for patients. Places like the Surgery Center of Oklahoma have easy-to-understand pricing bundles. This demonstrates it is possible to have transparent pricing that the average person can understand. This is not a partisan issue. Price transparency legislation is routinely a bipartisan effort. As for the general public, 9 out of 10 people believe all prices in healthcare should be disclosed. So how do we make this happen? The new Texas legislative session has started, and a bill has been filed that would put some teeth into price transparency legislation. Here's how it works. First, it would require hospitals to provide an estimate within 24 hours for patients who request one. Second, unless there's a complication or change in diagnosis, the final bill cannot be more than 5% of the original estimate. Third, if a hospital refuses to provide an estimate, it cannot collect the portion owed by the patient, it cannot report the patient to the credit bureau, and it cannot send the patient to collections or sue them. This means that hospitals have real monetary incentive to give meaningful price disclosures. We all deserve to be able to shop for the best medical care possible. Price transparency makes this a reality. Learn more about price transparency and other healthcare initiatives at texaspolicy.com. We'll see you next time.
We have a great panel. You guys you're in for a treat. I'd like to introduce them. If I'm able to read this font size, I'm going to struggle through it. To my left, and I'll take it in order, Genevieve Collins. Thank you, Genevieve. She comes with her own fan base.
Clearly.
She's the state director for the Americans for Prosperity in Texas and leads the Libre initiative, focusing her efforts on empowering every American by fighting for the taxpayer at the state and federal level. Her policy activism work includes healthcare policy, turning patients into shoppers, and giving them more control and choice over their care while increasing healthcare access and reducing cost. She spent 12 years in the private sector building
Education
iStation, thank you. I thought I was not seeing that correctly. Education technology company, and into one of the largest ed tech companies in the country. Genevieve is a 7th generation Texan and lifelong Dallasite. I did not know that that's what you called yourselves.
I know, isn't it? It's a terrible name, Dallasite. I think we really do need to change it, but yeah.
She is a proud graduate of the University of Tennessee and is a graduate of Southern Methodist University, where she received her MBA. Thank you for being here. The Honorable Chairwoman Stephanie Klick, what a champion for this issue, and thank you for being here. She is the state representative and represents House District 91. She currently works as a nursing consultant and graduated from Texas Christian University with a Bachelor of Science in Nursing. In total, Representative Klick, Chairwoman Klick, has over 40 years of nursing experience. During the 87th legislative session, she chaired the House Public Health Committee and served on the House Human Services Committee, as well as 5 other legislative committees and 3 state agency advisory boards. Thank you. And last but not least, Sean Kelley. Thank you for being here, sir. Sean is founder and managing partner of Texas Medical Management, a leading disruptive healthcare provider. Sean has nearly 30 years of business experience as founder and owner, with more than half in healthcare. His organization is disintermediating the healthcare market, and he'll tell us what that means, by direct contracting with health plan fiduciaries to deliver the highest quality health care at fair, all-inclusive, transparent prices. In his company's model, doctors win, patients win, and employers and payers win. Sean received his BBA and MBA at the University of St. Thomas and his master's at the McCombs School of Business at the University of Texas at Austin. Chairwoman Klick, I'd love to start with you. I talked about the fact that price transparency should not be a partisan issue. Last session was fairly divisive, and there was a lot of partisanship going on, but that wasn't the case for the price transparency bill that came through. Can you tell us a little bit about what you saw and what happened as it came through your committee?
Yeah, I think everybody's got healthcare cost, and if you have a car wreck, it's expected that you will go and try to find out in advance before you agree to have someone repair your car, that you know what it's going to cost and whether it's going to potentially cover the amount that insurance might reimburse you for those repairs. There's no other thing that we consume that we find out what it cost after we've already consumed it. That's not the way the rest of the world works, but it does in healthcare. And I think, more and more right now, Americans are paying more of their out-of-pocket hospital cost. You may have a $5,000, $6,000, or $10,000 deductible before insurance pays dime one. So consumers, both Democrat and Republicans, are consumers, are paying more of their healthcare cost out of pocket. And, it's a pocketbook issue with the members of the committee and other members of the legislature. People ought to know what it's going to cost in advance. Now, if you're having a heart attack or stroke, there's no time to try to get those cost estimates. You need care and you need it now. But on some of these elective procedures that can be scheduled at your convenience, there's no reason why you can't learn in advance what it's going to be. I mean, every family has got a budget, but you got to know what it's going to cost so you can know how to budget for that. And so, it's a kitchen table issue.
Very well said. And, some of the most recent statistics that have come out, some by the Kaiser Family Foundation and a number of other research groups, average family of four pays out a little over $22,000 a year just in premium. Sometimes that's shared with the employer, but that's a brand new car every single year, at least a VW Jetta. But in addition to that, you've got a deductible of anywhere between 5, 6. I've heard up to 10 and sometimes 14. I met somebody who had a large deductible. AHIP came out with information, the Association of Health Insurance Plans, forgive me with the acronyms, came out with information that basically said that nearly, I think it was over 75% of Americans don't ever hit their deductible. Well, that effectively makes us cash buyers, does it not? If it does, then should we not be able to see the price? As we saw in the video, seeing price per code makes it challenging for it to be useful to us if we need a procedure done. I'm going to come back to you, Chairwoman Klick. I understand that you filed a bill this morning. And could you tell us a little bit about that bill and how it's making it more useful for Texans if we can get it across the finish line?
The bill number is House Bill 3218, and as you said, it was filed this morning. When you are going to have an elective procedure, whether it be inpatient or outpatient, you can request to know what those bill charges are going to be for that procedure in advance. And the facility's got 24 hours to give you that information. And if they don't do that, and that bill has a variance of more than 5%, there has to be an explanation. And sometimes you can go in and have a procedure and there's a complication or something that does occur, but they have to give you an explanation as to why there's a variation in the cost. They don't do that. They can't send it to collections, which is hugely important. Folks may not know this, But there are a lot of hospitals now that are filing liens against their patients. And the dollar amount is not what the amount that everybody pays. It's the charge master rate, which nobody pays. It's a very inflated amount. It could be up to 10 times what the contracted rate might be for insurance. So, we think that on these elective procedures that they ought to be able to tell you up front what it's going to cost. There are providers out there that have models of care that do exactly that.
So the empowerment on the front end to give patients the ability to ask for an estimate, and then the patient protections and peace of mind on the back end. So thank you very much for your leadership. You all are getting breaking news on a bill that's just being filed today, and we're excited to see what it does and how it travels through the legislature this year. Genevieve, thank you for being here. I wanted to talk to you. You ran for office. You ran for U.S. Congress, but you had a very compelling story at a time when a lot of our House reps and senators at the federal level were shying away from health care. You were really leaning into the topic. Can you tell us a little bit about how you did that and why you did that?
Sure. Well, I'm thrilled to be here. Thank you, David. So I was the Republican nominee for Congress in 2020 in Dallas. I was the Republican nominee. And we had a global pandemic in 2020, and the only thing people wanted to talk about between March and November really felt like healthcare. And so I really wanted to demonstrate that as a conservative candidate, I wasn't going to be a part of another decade of candidates abdicating the issue, skirting the issue, and not talking about healthcare. Healthcare is something that affects all of us. And actually, it personally affected me on October 3rd. I contracted appendicitis. I don't know if y'all know this, but running for Congress is a little stressful. So I weirdly contracted appendicitis and had to go get an emergency surgery, and it became a whole ordeal, mostly because I had to wait 14 hours to get my COVID test back. They wouldn't operate on me before they had a COVID test, so I had to wait. And if you know anything about ruptured appendix, that's bacteria invading your system. Well, I had that for over 14 hours before they extracted my appendix, which is no longer a emergency item for emergency surgery for most hospitals. I found out that time too. But you should be able to know there's a lot of people without appendixes around here. This is not a very costly procedure. However, it almost cost me my life because a week later I contracted sepsis and went into septic shock and had to end up spending an extra 4 days in the hospital. I would say, the hospital staff in Dallas was incredible, and the nurses were absolutely spectacular, but they had no idea how much any procedure or any life support stuff that I needed, how much any of it cost. And so on the back end of almost dying 20 days before the November 3rd, 2020 election, I was given...
Not a great campaign strategy.
Turns out. Don't die. That's a great campaign strategy, but don't do it before an election. No, but the reality is, a week after I got back on the campaign trail, I wanted to finish strong, I got a $30,000 bill. And, this is something that's usually routine, shouldn't have been an emergency on the post side of it. And I just want all of Americans, I want every American to have the ability to be empowered, that the patient is the shopper, that the patient actually has a say in their care and can be their own best advocate, whether they're on the hospital bed or negotiating that up front. And that's why Americans for Prosperity is so involved and really on the front edge. Americans for Prosperity, the Libre Initiative, and Concerned Veterans for America are on the front edge talking to folks around the state of Texas, making sure we're hearing the stories so that Chairwoman Klick and her colleagues are hearing the real stories of Texans so that this stops. Every Texan deserves a chance to have great health care.
I know that Americans for Prosperity are championing an initiative called the Personal Option. Tell us a little bit about that and some of the initiatives, and is price transparency a component?
Absolutely. So, during Obamacare, there was this big thing called the public option. Well, it turns out that not that many people in the public want to be a part of the public option, right? So what we have come up with at Americans for Prosperity, we have 36 state chapters. In addition, we have a national lobbying or national policy organization in DC. And we believe in something, like you said when you first came up here, healthcare is personal. We believe that you should have a personal option, that you should be able to personally talk about your health care, your needs with the doctor of your choice, and that patients should be shoppers. So what we are really looking at are really 4 things. 1, making sure that there is more access to care. 2, making sure that we are reducing the cost of care. 3, ensuring price transparency. And 4, we're calling this mending social safety nets, like Medicare and Medicaid. These programs need to exist, but they need to exist for the people that need it the most. We don't need to put everyone under the sun on these programs. We need to make sure that those Medicare and Medicaid are protecting those that are most vulnerable and need that care the most, while we're giving more Texans and more Americans better access to care at a lower cost. So that's the personal option.
Thank you. Absolutely. I think I deserved a round of applause. Let me share with you. It triggered a thought about a poll that I see, and that I see it every year. And Rasmussen has been doing tracking this on a year-over-year basis, both at the state level and at the national level. And what do people care about when they're asked about healthcare? The number one concern is the affordability. How do we make healthcare more affordable? And I'm thankful for the folks here on stage that are actively doing that. That leads me to Sean Kelley. Sean, we mentioned Surgery Center of Oklahoma in the video, and I know that.
We've been here for a while.
What's that? Yeah, and we all know those guys up in Oklahoma. They're wonderful people. They're just not in Texas, and. So, Dr. Keith Smith, but I know that you went to them and talked to them, and tell us a little bit about that story, and let that roll into what it is that you do now.
Sure.
Because, and I want to ask this, as you tell a story, I want to ask you this question, or I want you to elaborate on this maybe towards the end of your story. The opposition to this bill, the hospitals predominantly, will say, we just can't do it. It's too difficult. It's too much of a challenge. It's just not something that can be done. And if it can be done, it's going to be inordinately expensive. It's going to be an administrative burden. And then they're going to talk about how it's going to hurt the rural hospitals, which we've talked to the rural hospitals, and I don't think that they believe that it's as much of a concern as the bigger hospitals that make much more money by being opaque. So tell us why it is possible.
Do you want me to start back at the beginning with the story? Okay, great.
I gave you a lot, I'm sorry.
Yeah,
but
no, that's right. That's right. David, thanks for having me. I appreciate it very much. Also 7th generation Texan, but from the Houston area. So, but we all meet here in Austin, right? At least 5 months every 2 years. I moved here in 2005. My brother finished his surgical training. I spent a decade inside a big hospital system and running surgical practices, developing surgical programs, service lines, et cetera. And I got to see exactly how things work, and then I also got to see the huge disconnect between the services that facilities were delivering and what they were actually collecting. Then I got to see the disparities also on the provider side, the people that are actually taking care of patients, the nurses, the doctors, the anesthesiologists. And so with that, after about 9.5 years inside the system, which turns out about 8.5 too many, my brother and I broke out. He didn't actually break out. I did, but he was with me, partner. And so what we did was, early on we decided, he said, I'm a reconstructive microsurgeon, so I get to do co-cases. So you'll have a surgeon, like an orthopedist, do a resection on like a femur, and then he'll come back in and rebuild it all. He does a lot of head and neck cancer stuff. And so he goes, I know the really good doctors here, really good surgeons. And so he had a little list. And that was the people that you called and said, hey, my daughter needs to go see somebody about her ear tubes. He's like, hey, go see Michael Yim. He's awesome. Because he had personal experience. So we started talking to these surgeons, and then we started talking to a few facilities, and we started thinking, well, we're going to build a facility. This is going to be great. And we went up to Oklahoma City. We met Dr. Keith Smith, cold called him, showed up at his door. He and his partner, Stan Peltier, thankfully dissuaded us from building a facility. They said, if you build a facility, you will be the slave to the BUCA payers for the next 15 years, and you won't do anything meaningful in this space being transparent, bundled priced surgeries by very high quality surgeons. Okay. After we got back from seeing him, we got to work, and we found willing facilities. We found tons of surgeons, because most people don't know that in the cost for surgery in this country, that $30,000, let me take a stab. I bet the surgeon probably got about $1,000. Okay. If you look at the total cost of surgery in this country, and let's break it down into a number called 100. Of that, $7 goes to the surgeon, $6 goes to anesthesia, a couple dollars goes to pathology and some other stuff, and then $85 goes to the facility. Nothing wrong with that, except the facility is an obvious place where we're going to need to cut costs. Because if you're going to try to cut the doctor's costs, the anesthesia costs, let me just be clear. Medicare's already doing that. Insurance companies are already doing that. It is already too low. So once we started building this program, we saw that there was a whole lot of interest, not just from the public. These are people that have those $10,000 deductibles that, you know, they want to come over. Why? Because they've got a hernia, and it's on our website. I think it's $4,800 all in. Appendectomy.
When you say all in, what does that mean?
Surgeon, anesthesia facility, pre-op, post-op with the surgeon, and for a hernia would include the mesh if that's necessary.
So $4,800 and no other payment.
None. No. Up front, we give you the price. If there's any changes up front, we'll let the doctor review it. They do what we call review and recommend. They may say, well, this person's actually fairly sick. Maybe they're an ASA 3. Means that their level of complexity as a patient is higher, so we might have to take care of them in a hospital. Well, then we also have a hernia that's done in the hospital, and it's about $7,000. Why? Because they stay overnight, and because it is more complex, and hospitals are more costly than surgery centers. So what we ended up doing was we built this out here in Austin, and then we started to connect with employers. Now, these are the renegades. These are the mavericks. These are the employers that have said, you know, if I have one more year that my broker comes in and brings me the hot mess that is Blue Cross, United, Cigna, Aetna, you name it, and it's going to be a 12% increase this year, oh, God, let me see what I can do. And they come back and say, I negotiate down to 8. These are the people that say, I'm done with that. Because we've gotten to the point now where my employees, I'm speaking as the employer here, the employers are saying, I'm giving them a benefit that makes them functionally uninsured. Why? Because you mentioned deductible. Deductible is part of it. Out-of-pocket max is another part of it. It's co-insurance, co-pays. So out-of-pocket max is $7,000 to $8,000 to $10,000 per member. So if you have a family of 4, it's usually a max of 2 times that. So you're talking about $22,000 in premiums. You're talking about $20,000 out of pocket before you get a benefit. So employers that are smart are saying this is enough. So one way to affect that cost is for these planned procedures, like you mentioned, Chairwoman Klick. It's very, very true. Hospital systems, and this will get to your question, hospital systems and others will say it's impossible for us to calculate the cost. Of course it's not impossible. Ask any business person that builds any product or service in this country that sells it for a transparent fixed price. Do you know your exact cost every time you deliver that service? The answer is no. You know more or less what it is, and that's how you price. But you know an average. You know what you can control and what you can't control. That's called risk. And so knowing the cost is an exercise. It's not that difficult to do. I do it today with the same facilities that tell me they can't do it. So we get contracts with ambulatory surgery centers, independent ones, big system ones don't want to talk to us. But every once in a while we have a case like an appendectomy or an emergency or urgent care, urgent case. Sometimes lap choles are that way, cholecystectomy is your gallbladder. We've had some kidney cases, we've had some liver cases, we've had some bowel resections, actually quite a few of those. But when it's a surgery that needs to be done in a hospital, I have a surgical nurse who runs our clinical operations, 20 years. He's phenomenal. He'll call up the hospital and say, okay, I want your cash price for these CPT codes. And they're like, oh, well, I don't know if I can do that. 15 minutes later, we're talking to the right end of the horse. We're talking to the OR nurse. We're talking to somebody who knows what they're talking about. And then they tell that person, yeah, it's these codes. Okay, great. I get a cash price. Their cash price is nowhere near what they're collecting from hospitals. But it's a kind of price that they have calculated internally. They don't want to share, but they've calculated internally that they'll sell to people like me as a wholesale price. And so then I build a bundle with that. And so I go to my employers, and appendectomy for us is $87.50. Okay? If it's
I would have much preferred to pay that.
Well, the thing about your surgery, though, is sometimes you're not in the right place, and you don't need to be getting in a car and driving a long way with an appendix. And yes, I do have a scar right here. I lost mine in 1988. And so I think the challenge is less about we can't calculate the cost. It's just not their normal way of doing business. Now, to be fair, and this is something I really want to say and be very clear about it. This hot mess we have in healthcare is not about the doctors and nurses. It's not. Period. Dissuade yourself of ever thinking that. That's not the problem. The problem is everybody in between, the doctor, the nurse, and the patient. It's all the people, as our chief medical officer, Dr. Rick Schultz, is an orthopedic surgeon. He says, we need to get all the people out of the room, don't add any value. And they muck it up. So what I would say to those facilities that might say, well, we can't do it, is, you know what? You can, and you ought to. Their biggest challenge today is they collect so much money from insurance company in the opaque, non-transparent part of the world that they feel like they'll have a difficult time staying in business because they're robbing from Peter to pay Paul. They collect this much from Medicare, this much from Medicaid. They do cash prices like this, and then they collect 6x from unwitting employers. So somewhere in that gamut of prices is a price that they can charge every single time and make money. And Medicare being really low doesn't help. Medicaid being really even lower doesn't help. So it gets balanced somehow. If you have transparency, it will increase competitiveness, definitely. And putting those type of back-end provisions is really smart because nobody's going to want to do this willingly. But overall, we're going to have a shift on the employer side to make all this stuff happen. Employers can't continue to pay $30,000 and $40,000 for operations that are profitable at $8,000 to $10,000. And that's something that I think employers have to take the responsibility for. They've abdicated it for a long time and need to take responsibility for.
Thank you. You know, I don't know if everybody knows my history. I'm a former hospital executive, CEO, did a lot of work in the rural communities. And looking at this would be an opportunity. I would see it as an opportunity. If I, as the hospital, could set a bundled price, perhaps I could recruit physicians to come to my hospital because I would be paying them cash. Because prices are transparent and bundled and upfront, people wouldn't be afraid to get the services that they need. People wouldn't be driving to the next city over, because that's what's happening to a lot of our rural hospitals is people are driving by their community hospital because they don't have a lot of physicians, they don't have a lot of services. But if you had that pricing, could that be a mechanism for driving up the business of that facility. I personally think that that is a strategy that could work. And I hope that that's something that could be employed by those groups and those organizations. Something I said yesterday, and I think I mucked up the quote, but it was something that was a piece of advice that was given to me by a physician mentor of mine when I was a young administrator. He said, nothing happens in a hospital except for at the tip of a doctor's pen. That's true. And here today, whereas 10, 15 years ago, 30% of physicians were employed, today it's more like 70%. So they've employed the pen. And that's why we're seeing prices go up and up and up. When you hear hospitals talk about consolidation and how they're going to save money by being a part of this bigger system, they're not saving us money. They're saving themselves money, perhaps, but they're also using that leverage to negotiate better and better rates with insurers and businesses so that they can charge more and more and get higher and higher reimbursements to the detriment of their communities. So it's important that we look at this as a real opportunity. But I'll tell you what, in this bill and the things that we've talked about, none of it works unless you as patients, and we all identified who the patients were earlier, it's still all of you. It doesn't work unless you ask for the prices. It doesn't work unless you are empowered, you have the agency to ask for the prices. Even in this bill, and it from my mouth to God's ear, it becomes law. It doesn't work unless you ask for the price. So I'm going to give us one more round if anybody has anything left to say, and if we don't, we can roll into Q&A a little bit early.
So I would just say two things. This is going to sound really simple, but also very odd that most people don't know that they can ask for a price. I mean, I know that sounds so silly and so simple, but as a consumer, as a patient, we are the ones that are paying the ultimate cost, and most people just don't even know that they have the power to ask for a price. I know that there's another representative from the Dallas area. Her daughter only pays cash. And I got to know, this is Representative Candy Noble. She and I've talked a lot about healthcare. But she was the first person that ever told me I could ask for a price from my doctor. And I know that sounds so silly. But to the point of just the crazy disparity in pricing, now that I am asking, hey, doc, how much does this cost? I asked my doctor that for a blood test a couple months ago. And he said, well, if you pay cash, it's $4. If you pay with your insurance, because I have corporate insurance, company, employer-based insurance, it's $181. And I wait, what? I mean, I almost fell off the little check-in bed, you know. $4 for a simple blood test. And if I used my insurance, which I could have, I would have still overpaid because I would have had a $20 copay on that same blood test. The insurance would have just picked up $159 of it or $161 of it instead of my $20. I mean, this is crazy. This is inflation at its core, and we're already dealing with the highest inflation we've ever seen. And I would just say one other thing, and I know these folks are a lot smarter than I am, but one thing in a recent Gallup poll, so from November to December of 2022, Gallup found that that folks were deferring their health care because of costs. The number one reason in not seeking medical care is the price. And that number is, the Gallup found, was 38% of Americans in 2022 were deferring their care. Now, I just want to put this in perspective. We all lived through something crazy in these last 3 years, a global pandemic. And people's fear of paying more rose in 2022. 2021, we were still in the midst of a pandemic. People were deferring their care by 26%. That percentage went up another 12 percentage points in 2022 over 2021. This is crazy that people are deferring their care. My stepmom, she lives in rural Texas out in Marion County, town of 2,100 people. And she's 69, pretty healthy, although she's got osteoporosis and has been a smoker for 40 years, so healthy is relative. But she's afraid to go to the doctor because now she's like, well, heck, they're going to find out all these things about me and it's going to get really expensive. And that's 100% not the point we want people to have. We want people to feel encouraged to maintain a healthy lifestyle, to know their bodies and to know what's going to be best for them and to have a personal relationship with their doctors. That is what we hear every single day as we travel the state, as we hear normal people just asking to have to pay a little less and not be scared of what the doctor's diagnosis or check is going to say.
If anybody's had a CAT scan or an MRI, you might be surprised to know that the patient that had that same diagnostic procedure after you may have paid a different price for exactly the same procedure. I was recently with a business group that are very interested in, because they pay their own claims. And they're very interested in the cost, and some of the stuff at the federal level puts them on the hook as a fiduciary, to make sure that they're getting good value for their employees. And some of the data I saw just out of hospitals in the Houston area, one of them was charging 800% of what the Medicare amount was. Medicaid is usually the amount on the very low end. Medicare is next, and then commercial. And so you could have a patient receiving services at that facility, and if they are Medicaid, they would pay this amount. If they're Medicare, they would pay this. And if they're a commercially insured patient, it would be 800 times that. That's crazy. If somebody went to the grocery store and you were charged for a carton of milk based on some of this, you wouldn't stand for it. Why should we in healthcare? I mean, we don't have to pay 800% of the Medicare amount. Medical is the most common cause of personal bankruptcy. This is why.
Absolutely. And Sean, before I get to you, I need to address something. You asked me to talk about something, and I forgot, and I recalled what it is. We were talking before the session, and Chairwoman was talking about how when someone goes to the hospital and asks for a cash price, it's not uncommon for the response to be, well, you have insurance, so we can't give you the cash price. It's illegal, or it's against our policy, or whatever the excuse is. Has anybody here heard that? A lot of hands just went up for those on live stream. That's bunk. That's not the word I wanted to use, but that's the word I'm using. It's not true at all. You can ask for the cash price. You're not breaking. Nobody's going to come and cuff you. Nobody's going to take you and put you in the back of a car. You can ask for the cash price. They are not in violation of any law that I am aware of or that even exists. You can get that information. They just don't want to give it to you. So I wanted to address that. You had asked me to share that, and you have. We'll get to Q&A in just a moment, sir. But I wanted to let Sean
I'll be quick.
have the final word.
Well, so thank you. I think interestingly, you talk about illegal and all that kind of stuff. I've had everybody tell me everything you're doing is illegal, and I'm like, good, report me. But when we go to surgeons and we say, we've evaluated you, and then our chief medical officer wants to interview you, and we've talked to anesthesiologists that work with you, we talked to nurses and techs, et cetera, and we really think you'd be a great part of this. Like, okay, well, what's the catch? You're going to bring me patients? Yes. Okay, what's the catch? I'm like, I'm going to pay you about 3 to 5 times what the insurance companies pay. They're like, okay, now what's the catch? I'm like, oh, and by the way, you don't have to collect anything from the patient. They're like, what? So I said, yeah. So I've talked to my employer clients, and they're saving so much money on the bundled price versus what they get through the network that they're sharing that with their health plan members. So every patient that comes to us from a health plan comes at zero out of pocket. It's even better. Our business partner has operations in El Paso and along the border. They take employees plus a spouse or someone else to take care of them, fly them into Austin, pick them up at the airport in a limo, take them in, like, put them at the Grand Duca here in Austin if they come to Austin, which is a very nice hotel. Put them up there, have a gift basket arrive in the room. Next morning, they pick them up, take them to the doctor's office, get their consult, and then a day or two later, they've got scheduled surgery, and they bring them around in a limo. Bring them back to the hotel. They convalesce for however many days possible as they need, and then they have their first post-op, and then they fly back. Any other post-ops are done via telemedicine, or a lot of times the surgeon will make contact with their primary care doctor if sutures need to be removed or anything like that. So we've been doing this now for 7 years. It is not as complicated as you might think. But the really important thing is this is good not just for employers. This is good for patients. You're getting a much better relationship with a doctor who's actually been reviewed by other doctors and nurses for their quality. But then you've also now, the employer saving so much money that they're willing to pay for all this stuff for you. And in fact, our business partners, beer distributor business, they pay a $1,000 cash bonus as well as no out-of-pocket cost. So there's a lot of money there for employers and others, municipalities, school districts. We have several school districts right now we're working with in this area, and they love it. I mean, you talk about delaying care. I mean, we go to the kickoff meeting for Lockhart ISD, and there's 3 people hobbling into the meeting, and they're like, well, I don't know when this is getting started, but I hope it gets started soon because my knee's been bad for 3 years. You would not believe how many people are delaying care. To your point, the number of stage 3 and stage 4 cancers is going through the roof. Why? Because people are scared. They don't want to go get a $6,000 MRI or a $10,000 CT scan. So rather than do that, they wait. And then what happens? Colon cancer is very curable if it's caught at the right time. Breast cancer, most types are very curable if caught at the right time. Modern medicine has given us so much, but for us to be scared to death to even find out, not psychologically, but financially, we're scared. That's real pitiful. When you talk about access, that's a restriction on access. Thank you.
I want to end this time with a personal story. It's not the same cough I'm going to talk about in the story, but I had a chronic cough post-COVID, and my doctor was concerned. He says, this is going on a little bit long, David. I want a chest x-ray. And so I thought, you know what? This is a great opportunity to see how we can shop and show people that we can shop for prices. And so I went to some local hospitals here, went to their website, found the code for what a chest x-ray is. It's one code. And at one hospital, it was $675. Another hospital was $548. So I said, let me try a standalone diagnostic imaging center here in town. And I tried 2 of those as well. One was $60. And mind you, the hospital prices, that was just the x-ray. It didn't include the read from the radiologist. When you talk about the diagnostic imaging, it was bundled. So it was the imaging and the read. So it was $60. And then I tried another one, green imaging, which is where I ended up going, and that was $52. So that's where I went. It was great equipment. It's a good outcome. It was a good image. And I was much happier paying $52 or $50 than $600 and some odd dollars, as you all can imagine. We look out for our own best self-interest, and we want to save those dollars. We are cash buyers. That's what it comes down to. So with that, I'm going to open the floor up to you all. I have really one request, and I will mock you if you don't keep up with it. I'm going to ask that your statements are in the form of a question. We've got some great resources up here. Let's please ask some great questions because I think you'll learn a lot. So let's start. This gentleman here in the front.
Representative Klick, in the bill that you put forth, does it also have something in there where it's easy to search the data? As David showed early on, a massive spreadsheet, and I played around online late last night and found a massive spreadsheet, and it wasn't in Excel format. I don't know how you search for the price when you go through 6,000 lines or whatever.
But on this, in this particular bill, it's about an individual patient, not any possible cost that a patient would be associated with, but one uniquely for you.
So the price would be, you request an estimate, they're providing you an estimate. There's no searching a spreadsheet. You're
Right.
provided with the information.
An actual question for you, David. You know, a lot of talking about individual facilities, you know, x-rays, surgeries, and so forth. What I see on the primary care side of it is related to labs and prescriptions. Your story about labs, I get, you know, complete blood counts, cholesterol, $3, $4, you know, price of a cappuccino. But prescription prices, and I see a lot of people will go and they think they know what their cost is going to be, and then the insurance company gets them around. They sneak around it, and I see this with labs, 1,000% increases. So $100 for a total cost for a whole panel. Insurance denied it. LabCorp sent them a retail bill for $2,400. So that's how they're sneaking around the transparency. They said, here's our transparent price. Then they hit them from the back end. How can we stop that?
I think it really depends on what type of service you're talking about. The pharmaceutical part of it is very, very opaque, and that one is a harder nut to crack than some of the others. You know, if you're getting the price in advance, like this bill would require, they can't go up on it, and they can't send it to collection.
And in the purchase of medications, I encourage everybody, ask the cash price. If it's a generic, ask the cash price. There are cash only pharmacies. I think I've mentioned them before. Mark Cuban's Cost Plus Drugs, Scriptco. Those are 2 Texas online pharmacies, and they disclose how they make money. They show what their profit is and what their cost is. Medications are pennies on the dollar as opposed to hundreds and thousands of dollars.
And if you're going to be taking that medication long term, ask for a 90-day fill, because you'll save money on a 90-day fill versus a 30-day fill.
I would just add quickly, there's a bill filed by Representative Matt Shaheen, I think it's 593, and it's looking to expand the code saying that any provider that wants to practice direct primary care, we can expand that code. And so we want to make sure that there are more direct care providers that I think that would really ensure that no one's doing some back-end hocus pocus. So support that bill.
And I'll just say real quick, I've had direct primary care now for 7 years for my family and me. And if you don't have, it's hard for us to be great fiduciaries of our own health care because of what we don't know. Having a direct primary care doctor, game changer.
Yes.
They'll tell you, don't go there, they charge a lot more. Go right there, they're very good, and they'll give you the price up front. Don't go to that pharmacy, go to that one. It's like complete game changer.
And let me, and if I may, I want to, and I use direct primary care as well. What we call healthcare in this country, it's not healthcare, it's sick care. Because when we use insurance, the only way that doctor can make any money is by submitting diagnosis codes with procedure codes. So there needs to be something wrong with you for them to be able to make money. That's sick care, that's not healthcare. Direct primary care is one of the few models in this country that has a reimbursement methodology that is focused on health care. They are financially motivated to make sure that you are healthy, that they're looking at preventative measures to do what it is that you want to do as a person, for you individually. Yes, sir.
So let's say that we do want to shop around for our medical treatment, our pills, the procedures. Could you go into some more detail on where we would find those medical codes? How do you compare across websites of different medical facilities?
In the example that I gave about my chest x-ray, did you want to talk about that?
You know, sometimes you are able to get the actual procedure that you're going to undergo from the physician, and you can get something called CPT code or Common Procedural Code that you can make those comparisons. There are some other sites like Healthcare Blue Book that can give you a range based on your zip code, and there are also other sites like that that can give you a range of what those costs may be.
What I did personally was I asked on the prescription, it had exactly what the test was that he wanted. And so I typed in CPT for chest x-ray, 2 views, because that's what it was asking. And it gave me a code. This, I can't remember, 77256, I think. That could be way off. And then I went to the websites, looked for that code, and then looked for the commensurate cash price. And so that was how I was able to do that analysis, was get that code, go to the websites, find the corresponding cash price for that code, and I was able to look at the hospitals and the imaging centers. It is not as much for medication, but for medication, what I use is I will go to those 2 companies that I mentioned, the ScriptCo and the Cost Plus. I also use GoodRx pretty frequently. You're going to get more of the retail dollars, but that's a good barometer. Did you have something you were going to say, Sean?
Well, on medications, there's funny ways that if you take GoodRx, okay, if the doctor prescribes you twice a day, 500 milligrams, okay, so you look at the 500 milligram tab, and let's say it costs 10 cents, great. But if you look at the 1,000 milligram tab, you'd be surprised it costs the same amount. And it's scored right down the middle. So, right, I'm from Texas, but I got math. You can just break the damn pill in half. And so that's what I do for some of my medications. And I save 50%. And so I get around the bad people by just like using my wits a little bit. There are other ways. If you go to the big pharmacies, the CVS's, the Walgreens, all those are all owned by insurance companies now. Or actually, they bought insurance companies, which is the craziest thing. But if you go to your local pharmacy and you just talk to them and say, look, this is my medication, they will tell you how much they can give it to you for. And if you use GoodRx, they'll tell you, just be fair with them. And we have to keep these people in business. Because if we don't, then on every corner we're dealing with an insurance company-owned giant mega corporation pharmacy who, your example earlier about paying $20 for something that costs $4, that happens all the time with prescriptions. You'll have a drug copay, $20, specialty drug, $45. You'd be surprised, 80% of the time the drug actually costs less than your copay.
Gentlemen, the mic, and then we've got Scott over here afterwards.
My question is to any of the panelists, health savings accounts. My understanding is that they empower patients and help with price transparency.
Well, absolutely. This is one of the things that Americans for Prosperity is advocating on at the federal level. So we work at the state and at the federal level. We've helped author the direct primary care bill with Representative Shaheen here at the state level. But at the federal level, we have been rounding up congressional members. I said that in a nice way, working alongside David here, making sure that they know that expanding HSA accounts is like giving people a retirement account for their care. And this is really putting patients in the driver's seat, giving them control of how much they can afford and really allowing them to direct their dollars. I see that their father, or the architect of HSAs, is in this room, Dr. John Goodman. So want to make sure he gets some... But this is one of the best things that Congress can do. And again, this is a winning issue. I think Speaker Phelan said this best. This is a winning issue for Republicans. And if Republicans get on the free market healthcare paradigm and that they can lead on this issue and not just roll back and just keep abdicating the issue, then they can win, and they can win and help Americans win by getting HSAs.
You know, the limit for, you have to have a high deductible health plan to be eligible for an HSA. And The lower limit, I believe, is $2,500 because back when they were started, that was a high deductible. I would love to have a deductible of $2,500 these days.
David, the employers we work with give away so many free services, they don't even qualify for HSAs.
Yeah, and that's very true. That we, as wonderful a tool as they are, and there needs to be some reform to the system because there've been so many developments. So you cannot use an HSA for a direct primary care doctor. What was I going to say? For those that don't have high deductible health plans, like myself, I use a cost sharing plan. I can't have an HSA. So there are some things that I think that should be done and could be done at the federal level, and I believe that there's a great bill that already has been filed again by Representative Chip Roy and Senator Ted Cruz that does a lot of these things that we're talking about.
Thank you, David. Because you segued in my question. Years ago, my deductible was $2,000. Now it's $8,000. So a couple questions. I don't know if you can put this in this bill because the HSA, you use your own money in the HSA, but you cannot use that towards your deductible. Question one. Question two, I get a cash price. They won't let me use it toward my deductible. So what is the deductible good for unless you go for the regular price? So if somehow we can fit that into it so it helps us, we're doing this, and that way we can offset some of that $8,000. Thank you.
One of the things I will say is the HSA that is federal, not state. That's right. And so there's limitations that I can't address it in this bill.
But there are some bills, I will say, I don't know if you've seen them yet. I can't remember. I think I've seen it in 3 different bills where if you do find the opportunity to pay for something cash, then that could be applied to your deductible.
I believe pharmacy benefit managers, or PBMs, are the most unnecessary part of the healthcare. It's a little workaround created by the insurance companies who own the PBMs, who in turn dictate how the pharmacies dispense medications to you when there is no need for them to be involved. If there is a true middleman in the whole healthcare equation, that's a PBM. Is there any way we can work on, along with your bill, maybe not this time, but in the next session, to have PBMs eliminated altogether?
There are several bills by some of my colleagues that are dealing with PBMs. And, there are things like, some of the provisions don't apply to Medicaid, but they do, some apply to private commercial plans and others don't. So there's a variety of different schemes as far as how PBMs, depending on who your plan is.
Thank you for your question. Many people are going to think that you are a plant. And can you confirm that I have not paid you whatsoever? No, I don't think it's possible or actually prudent for us to eliminate them altogether. If they, on a fixed fee basis, they provide an invaluable service. It's just that the problem started with the federal government. They benefited from a safe harbor from the anti-kickback statute in 2003. That, if you can track list prices of medications from that point in time, and it grows at near an exponential rate. So it's the intervention of the federal government that has created an actor that is functioning as a fiduciary. I hate to say it. They are doing what is legal, but is it what is right? And that's what we all believe to be not the case. And that's what needs to be changed. But what we can do at the state level is require more transparency. Yeah. Is there a gentleman there?
So a lot of states have moved to a lot of low-risk drugs, being able to get them just from my pharmacist and not having to go to the doctor all the time, such as...
What was the question?
Just, would that be a way of saving money?
There is a bill that's been filed called Test and Treat. But it's limited, to some conditions. Example might be a strep test or a COVID test. but it's limited to a few conditions. So that's something that we'll be discussing this session.
Absolutely.
David, also the other side of that is physician dispense. And we're only, what, one of 2 states? 4 states. So there's 46 that allow it. And DPC in other states, like Kansas, I know a gentleman up there, a doctor, and he buys all his medications in bulk, all the maintenance medications, and he gives them away to the patients because they're pennies. They don't even have to go through the pharmacy. They don't have to go to GoodRx. They don't have to do any of that. And so physician dispense for a limited scope of generic medications is, I think, would be smart.
And what I've seen this session that I have not seen in others is that pharmacists and physicians are coming together to collaborate because they are facing the threat of the PBMs and the insurers really pushing them out. We'll have a mic to this gentleman here. Let's give it to, we'll go right afterwards.
I was just going to say, on the test and treat, Florida has a test and treat statute. It's been great. It was passed a couple of years back. It was exceptionally helpful in COVID. I know that's not a question. I just wanted to interject.
Sal, you don't get to come here and flex for Florida. You're in Texas. It's Texas Independence Day, so I shouldn't have given you the mic.
Sean, you mentioned that employers need to take some responsibility for this. And so I would say a twofold question here. One, what are some things that they could be doing on their own to really start taking control over this, to take advantage of transparency? And then I guess for the rest of the panel, what are some other bills that employers should be supporting that could help them in this process?
Well, I think first and foremost, they ought to all get ready, because when we say transparency, the Transparency Act and the CAA, all this legislation, the one thing that's very clear is it outlined the very specific targets for fiduciary responsibility under health plan benefits. So as everybody is probably aware, over the last 30 years, on the retirement side, employers have had lots and lots of fiduciary lawsuits. It has been extremely well litigated by plaintiffs' attorneys. That's coming to healthcare. So when I say employers need to take responsibility, it's like at their own peril, right? I know of plaintiffs' attorneys across the country right now that are building up war chests of millions of dollars to go after employers for continuously buying bad valued care for their members. So that's one. Specific things they can do, I think, that are right out of the box is they need to have an ability within their self-funded plan to actually use direct contracts. So whether that's with Dr. Porter over here at Direct Primary Care, or with Green Imaging, or with our company, or whomever will give them good services for value at a transparent, knowable price, they should enter into those agreements, because all they're doing is they're going to create the conditions in their own communities where they can save money. Because none of those providers I just mentioned enjoy taking the insurance haircut. Nobody likes to be denied. Nobody likes to have to collect $10,000 from an employer. It's a win-win-win. Employer wins, the provider wins, and the patient wins. There's very few of those things in life. And then I think your last question was,
what are some of the bills in the legislature this session that employers should be supporting to help them along this path?
okay, so I'm going to pass that down.
And I'm sorry I don't know the bill number, but there is a bill filed by Representative Franks that I am helping him on. And it is a insurance product that has no mandates on it. You know, Obamacare has a lot of minimum coverage requirements, and some of those are really expensive. Anytime we add a mandate or something that must be covered under insurance, your premiums go up, your costs go up. And so Representative Frank's bill, and I'm a joint author on, will offer a plan that is mandate-free. And you will see a significant savings in premiums on a plan like that.
I mean, that would be huge. I would just say from a bill perspective, Americans for Prosperity is going to be 100% behind you and with you on this price transparency bill. So we're going to be, so I would also just say, so there's a couple other interesting bills. There's one about expanding direct primary care that I think employers should look at. There's another bill that Americans for Prosperity's worked on with Matt Shaheen around expanding telehealth services potentially to out-of-state providers. There's a lot we have to work through on that, and I'm sure you're going to get to hear a lot about that. But the reality is we have a doctor shortage, and we got to find ways to increase access while decreasing cost and in making sure care is immediate. So looking at expanding telehealth, and then I think what you've been working on from the rural doctors side, rural care is going to be really important. If everyone doesn't know, I think you should share a little bit.
We're looking at somebody else is doing something. We're looking at graduate physicians, and I know that this is something that is of interest for a lot of folks, especially in the rural communities, is medical school graduates, physicians that have not matched into residency. They're an incredible resource with lots of clinical hours of training that we can use under the supervision of a licensed physician in Texas, in rural Texas. So looking to improve our workforce. Also, there's another great bill by Chairman Frank, I think is HB 711, that eliminates a lot of the anti-competitive contract provisions between hospitals and insurance companies.
And he's also got the one that outlaws facility fees.
Yeah, the site neutrality. Yeah. Do you all know what site neutrality is or facility fees? May I? Actually, Sean, go ahead. You can do it much better than I.
No, go ahead.
Okay, well, he's punting it back. I'll tell you a story. There was a physician, had been in practice for 25 years. Patient had been going to him. The bill was relatively the same each and every time. The doctor was getting nearer to retirement and decided to just be employed by the hospital and sell his practice. Well, the patient goes back after that acquisition by the hospital. Their hospital name is on the building. It's on the glass. He's going in, seeing the doctor. It's now an extra $150 more. Why? Because it is now a hospital outpatient department, an HOPD. And because of that, in the billing, when they submit that to the insurance company, the place of service is that of a hospital, not of a doctor's office. And so that's what we're talking about in site neutrality. If you're going to a hospital, that's expensive real estate, that's fine. But when you're going to a doctor's office or a standalone imaging center, those are not hospitals.
That's correct. And in surgery centers is actually, if you go to a hospital-owned surgery center, if it was grandfathered in at 2020, I believe, 2021, is when they outlawed it going forward. But if you were grandfathered, if you're owned by the hospital, it could be anywhere in a community, you get 90% more than an independent-owned ambulatory surgery center. So the big companies are really good at lobbying in Washington.
Yeah. We have time for one last question. Dr. Van Skyn.
Hello. So prices are important. I love all the work that you are doing. What else can we do to get government out of healthcare? Because y'all are trying to go around the edges here and there, but how can, because ultimately we need a free market in healthcare, just like we do with other things. That's why, you know, and so ultimately these are we cutting around the edges of healthcare when we need to let the market work. But I think that's mostly at the federal level, though, right? There's probably not a lot you can do in the state. This is really probably Congress and everything. But I'm just wondering what else we can do in that sense in Texas.
If you don't have competition, you don't have a market. Exactly. And in many areas, we don't really have a true market. You know, we need to support a free market.
And respectfully disagree. I don't think that these are necessarily around the edges. You can't have the beginnings of a market if you don't know what the price is. That's the signal that really has the semblance of a market itself. So I think that this strikes at the heart of having more of a market dynamic that is badly needed in this industry. But thank you so much for your question.
Yeah, and just to add one last thing, the people who purchase healthcare are the ones who are going to make this change. if we don't make this change, if we don't go to our employers and say, you know what, I'm not paying $24,000 a year for my family to have insurance, and then have an $8,000 deductible, $10,000 out of pocket. I'm not doing it anymore. Until we do that, everybody's just sleepwalking because they're continuing the system. The system just keeps going. We all have to take charge of it. And that means sometimes doing things differently than whipping out the Blue Cross card, right? We're a part of the problem too. Get a direct primary care. Just test it out for 3-6 months and just wait till you find out just how much of your health care can be taken care of by a primary care doctor whose incentives align with yours.
Chairwoman Klick, what is the number on that bill again?
My bill is 3218.
3218. Thank you all very much for being here. Let's give them a round of applause.